speaker is Dr. Savaş Ceylan, and he will talk about endoscopic approaches to cervical craniovertebral junction. Please, Dr. Ceylan.
You must unmute yourself.
It's okay?
Yes. First of all, I would like to thank for this kind invitation, Professor Zileli, dear chair, and their colleagues. I'm going to talk about endoscopic endonasal transsphenoidal approach to craniocervical junction. Sorry. Endoscopic transsphenoidal approach has been performed first time by Jankowski, but the detail of this approach has been described in detail by Joe et al. This established technique have been used by many authorities from different countries. Endoscopic transsphenoidal approach include two approaches, standard and extended expanded approaches. These extended endoscopic approach have been used to reach from lamina criprosa to craniocervical junction. All middle midline skull base lesion can be used extended endoscopic approach. And the lower clivus include craniocervical junction. These anatomical landmarks, lower clivus and the odontoid tip, anterior arc of C1, craniocervical muscles, and buccopharyngeal fascia. Sorry. Transcranial and endoscopic approaches, the clivus is divided into three parts. These are superior clivus, middle clivus, and the inferior clivus. Inferior clivus contain lower clivus and craniocervical junction. For this region, we routinely use transclival and transodontoid approach. Median and the paramedian lesions are very suitable for extended endoscopic approach. All pathologies involving clivus and craniovertebral junction, these are malign neoplasm, most common chordomas, chondrosarcomas, pituitary adenomas, petroclival meningiomas, and the other non-tumoral lesions. Endoscopic approach has been performing in 6,000 cases in our clinics since 1997. The most common pathologies, chordomas. Chordomas are tumors developed from extraaxial and the notochord residues. This tumor grows slowly but aggressive tumors. Because of similar presentation of radiological appearance, chondrosarcomas are discussed together with chordomas. We reported our experience with 72 cases with chordomas and chondrosarcomas 3 years ago. Of these, 9 cases located inferior clivus and craniocervical junction. In the series, our gross total resection rate 75%. Essentials of surgical treatment. Surgery is the most effective treatment option. The volume of residual disease has a major effect on disease course. Initial treatment attempt has the highest chance of success. High-dose radiation therapy should be considered in all cases. This surgery should be performed at centers of excellence. The operative nuances in the surgery, these are tumor relationship, very important. The other nuances, tumor extension and localization, and the tumor adherence and consistency, and the recurrence. In this report, we describe anatomical limitations, extradural and intradural. Extradural limitations for lower clivus, bilateral occipital condyle laterally, and the C1, C2 inferiorly limitations. Our first case, 10 years old girl patient, this tumor extended choana, tumor involved choana. Firstly, we performed internal decompression. After internal decompression, and the tumor capsule was dissected from surrounding structures, and then we reach lower clivus. You see lower clivus. This tumor destructed lower clivus, but we remove lower clivus to access superior extending tumor, and then we reach a lower clival tumor. Firstly, this tumor was resected with ultrasonic aspirator and the other instruments. In this case, we explore and we reach inferior part of tumor. And in this region, we explore occipital condyle and atlanto-occipital joint. You see, atlanto-occipital joint and occipital condyle. And now lateral extending tumor was removed. And then in the last period, we reach retroodontoid area, and tumor capsule was open. In this region, in this retroodontoid region, we went as deep as we could. We reached the deepest point of tumor, and this retroodontoid tumor was removed. And the other case, in this case, we performed stage surgery. In the first surgery, we removed lower clival tumor, and the second surgery, we performed transodontoid approach, and we reach C1 arc, and the lateral left side C1 anterior arc was removed, and then we reach condyle. In this case, we performed medial condylectomy to reach a lateral extending tumor, and we explore now we removed medial condyle, and then we explore lateral extending tumor, and this tumor was removed. The other case, this case very interesting case, 3 years old boy, tumor involved craniocervical junction, and we reach C1, you can C1 and odontoid tips, and the tumor was dissected from tectorial membranes, and this tumor is removed near totally. Pathological diagnosis, the differentiated chordomas. In the other case, this huge tumor, extradural tumor, extends odontoid tip and craniocervical junction. This extradural tumor was resected totally. We reach craniocervical junction, and we explore anterior arc of C1, and then lateral condyle was explored. And this case, the inferior point, we control vertebral arteries with Doppler, and this tumor is removed totally. In this case, we try to access extradurally hypoglossal canal. The other case, this case is one of the last cases. This firm tumor, very hard tumor, we perform transodontoid approach. We explore tumor capsule, and capsule is opened, and then a tumor was removed intracapsularly. For intradural tumor, limitations for lower clivus, hypoglossal canal, and foramen jugulare laterally, and the medulla oblongata inferiorly. In this tumor consistency is important for resection. The first case, huge tumor, extends odontoid tip and craniocervical junction. Firstly, extradural tumor was removed, and then infested bone and tumor is removed from intradural region and the basilar artery and the pons and 60 nerves. And in this case, we reach lower cranial nerves. The other case, this one of the most difficult cases in our series, huge intradural tumor. Firstly, we explore clival dura, and then clival dura opened vertically, and then we explore tumor. This adherent tumor, firstly dissected from right side pons and medulla, and this tumor dissected and resected, and we explore lower medulla, and you see lower cranial nerves. In this case, after tumor resection, and you see basilar arteries and pons and medulla. In this case, we reach lower cranial nerves, you see, and then we access hypoglossal canal in this case. The other intradural tumor, this tumor involves craniocervical junction. We reach craniocervical region, and firstly, extradural tumor was resected. We used ultrasonic aspirator. And then this is interesting case. We explore clival dura. There are many dural defects. We removed intradural tumor through these dural defects. We removed all pieces of intradural tumor components, and at last stage, last piece of tumor was removed, and then we reach pons and medulla. We explore pons, and the medulla, we explore lower cranial nerves. The other pathologies, craniopharyngiomas, this case was operated 4 times previously. We operated last type, and this tumor is removed totally. This tumor extends craniocervical junction and odontoid tip. This tumor was resected totally. The other pathologies, complex meningiomas, is very difficult cases. This tumor extend cavernous sinus, sphenoid sinus, prepontine area. In this case, firstly, sphenoid tumor was resected, and we open cavernous sinus. You see anterior wall of cavernous sinus. We enter lateral compartment of cavernous sinus, but very firm tumor. We resected with ultrasonic aspirator. Total resection was performed. The other complex tumor, this case is one of the last cases. Tumor extend sphenoid sinus, cavernous sinus, and craniocervical junction and odontoid tip inferiorly. Firstly, sphenoid sinus involved tumor was resected. At this stage, we perform extradural dissection and resection, and this tumor was resected. And then the second stage, in this case, we open cavernous sinus. You see, cavernous sinus anterior wall was open, and we continue Doppler, and we enter lateral compartment. A very firm tumor was resected with ultrasonic aspirator. At this stage, we routinely used Doppler, and the tumor was removed from between horizontal paraclival and petrosal segment of carotid arteries, and the last stage we reach craniocervical junction, and extending tumors was removed. The other pathologies, giant cell tumor. This tumor are very interesting tumor. This tumor very hemorrhagic tumor. You can encounter massive hemorrhage and bleeding. In this case, therefore, we stop first operation. This patient was embolized. After embolizing, this patient was operated again, and this tumor removed totally. The other pathologies, pituitary adenomas, some huge giant adenomas extend a craniocervical junction and odontoid tip. This tumor extend lower clivus, and also it extend prepontine area, retroclival area, and this tumor was removed near totally. Recurrent cases, endoscopic approach can be used very easily. This case and the second surgery, lower clivus involved tumor was removed totally with extended endoscopic approach. In the last case, basilar impression and the other congenital pathologies, you can prefer transodontoid approach. Endoscopic transodontoid approach, very easy approach. We used routinely vertical incision, and we opened buccopharyngeal fascia, and then we dissected craniocervical muscles, and we reach C1, and we drilled C1 arc, and we explore odontoid tip. In this case, we removed only odontoid tip and odontoid bases preserve, and you see after removal odontoid tip, we explore transverse and the other ligaments. In these cases, endoscopic technique is more confident and effective in midline and craniocervical junction lesions. Combined approach should be preferred when necessary. Gross total resection is main purpose. Surgery should be performed in experienced multidisciplinary centers. Thank you for your attention.
Thank you very much, Dr. Ceylan. Excellent lecture and beautiful cases.